Okay, it's 6:30. Good morning, everyone. So, as always, Monday morning, 6:30, we are starting our next class. And very important topic, rehabilitation. I think we know a lot of things about rehabilitation, but systematically, if we really want to rehabilitate a patient who needs palliative medicine, palliative care, or who is having palliative care needs, how should we go about it? It will be taken by Dr. Gayatri and team from MNJ Institute, Hyderabad. I request Dr. Gayatri. We all know Dr. Gayatri, so there is no need to introduce her. But on a personal note, I really want to say that Dr. Gayatri is a very good friend of mine and a good friend of palliative care community of all of the country. And the way she is working and is spreading the message of palliative care all over country, plus focused in Telangana. I think it is something we should is something to learn from her, and absolutely dedicated and committed person. And that's why palliative care has grown so much because of people like Gayatri and few more. So thank you very much, Gayatri. And please introduce Archana and go ahead with the class.
Thank you very much for the kind introduction, Dr. Sushma. So, without wasting much time, Dr. Archana Vajjala, she is our second year DNB student from Department of Pain and Palliative Medicine, MNG Institute of Oncology and RCC, Hyderabad. And she has many publications in national journals and international, and attended many conferences. Recipient of a APM bursary for APCON 2023, and she says she has a special interest in nephrology and key area of interest end-of-life care, pain management, and communication. Over to you, Archana, for the presentation.
Thank you for the introduction, ma'am. A very good morning to everyone. I'm Dr. Archana Vajjala. I'm a second year DNP resident in the Department of Palliative Medicine at MNG Institute of Oncology. Today, I'm going to talk about palliative rehabilitation, and I would like to begin with this quote. The work of all professional team is to enable the dying person to live until he dies at its own maximal potential, performing to the limit of his physical and mental capacity with control and independence whenever possible. This was a quote by Nicky Giovanni, an American poet, back in 1943. So to begin with, the aim of today's session is to explore rehabilitation in palliative care and to consider how principles of this palliative rehabilitation can be incorporated into our regular practice. Let's first define palliative care and palliative rehabilitation. Like we all know, WHO defines palliative care as an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, impeccable assessment, and treatment of pain and many other problems, whether physical, psychosocial, or spiritual. Palliative rehabilitation, on the other hand, is a process of helping individuals with progressive, often advanced or incurable diseases reach their physical, psychosocial, consistent with physiological and environmental limitations and life preferences. So research conclude that palliative rehabilitation is known to prolong functional independence and improve quality of life. That is something very important for us as palliative care physicians. Rehabilitative palliative care, rehabilitation and palliative care combined together, they aim at optimizing function and well-being of a patient to enable them live as independent as possible, with utmost importance given to autonomy within the limitations of advancing illness. So we try to focus on optimizing function and make the patient live as independent as possible, respecting autonomy and keeping in mind the limitations of advancing illness. It also empowers people to adapt to the new state of disease or diagnosis with dignity. Provide support to anticipate and cope with losses from deteriorating conditions. So these are the three important things we primarily focus on palliative rehabilitation. Introduction. Many patients suffer from life-limiting illnesses with severe degree of symptom burden, and this in a way affects their normal functioning negatively, causing debility. If we don't address this debility or if not considered, it can cause increased dependency, psychosocial distress, neurological and musculoskeletal deconditioning in due course of time. All this together, added to this, the new symptoms that appear secondary to the disease, like pain, fatigue, dyspnea, all together can cause decline in performance status and affect the activities of daily living. Altogether, I can say it can reduce the quality of life both patients and their caregivers. So, palliation and rehabilitation for a long time are considered to be two important components of comprehensive personalized care. But some consider this as unlikely combination because as palliative care physicians, we primarily focus on life-limiting illnesses, whereas rehabilitation focuses on recovery and full functionality. But are these fields somewhere interdependent? So, like I said, early introduction of palliative care in life-limiting illnesses is evidenced to improve quality of life and longevity. We all know that early introduction of palliative care can improve quality of life. Whereas rehabilitation, on the other side of the coin, enhances functional independence of the patient, leading to improved activities of daily living. Now, combining both together, integrating these two together, the relevance is in the fact that both aim at improving comfort and functionality, keeping in mind the patient and family goals to improve the quality of life, regardless of life expectancy. So, combining these two fields or these two together, we focus on improving comfort and functionality together, regardless of the life expectancy of the patient. So the interface of palliation and rehabilitation, some similarities. How are these two similar? A lot of evidence conclude that rehabilitation and palliation focus together to decrease the symptom burden and improve the functionality of the patient. And both work through different lines, both have different frameworks, guidelines, and practices, but both are characterized as interdisciplinary fields. Both have quality of life as an overarching goal. And especially in aging population where we have complex needs to be addressed, complex social needs and healthcare needs to be addressed. In such situations, palliation and rehabilitation find to share a common space, most common in geriatric group of population. Interface of palliation and rehabilitation and how it works. So like we just discussed, palliative rehabilitation supports adaptation to activities of daily living to maintain best independence physically, along with emotional and social backing, increasing the quality of life and equally respecting patients' wishes. The interventions that are commonly seen in palliative rehabilitation can help with pain, dyspnea, edema, prevent contractures, ulcers, correct positioning, breathing assistances, relaxation or use of assistive devices. These are some of the interventions that we perform in palliative rehabilitation. Some interesting literature behind palliative rehabilitation. In the recent past, palliative rehabilitation is gaining a lot of importance and attention globally. There are numerous studies that conclude that palliative rehabilitation is known to improve or have a strong positive impact on symptoms like fatigue, anxiety, mood, pain, functional status, and all improving quality of life. These are the symptoms that we regularly encounter in our practice and focus on. And readiness of acceptance of palliative rehabilitation was more seen in some kind of cancers like head and neck. I think the reason behind this is head and neck cancers are more treated with radiation, and conditions like dysphagia, trismus, neck contractures or fibrosis, all this can be helped with interdisciplinary team involvement, including the physical therapist and all. So I think head and neck cancer has got a significant role to play. Palliative rehabilitation has got a significant role to play in head and neck cancers. And some studies concluded that palliative rehabilitation, not only at home, hospice, in various setups, has had a positive impact. A systematic review in 2015 and 2017 showed that physical exercise had a significant improvement in quality of life, mood, and general well-being when implemented among advanced cancer patients. Many of us work in cancer setups primarily, so incorporating physical exercises showed a significant improvement in quality of life. Education about palliative rehabilitation among patients and caregivers improved physical health of patients. And palliative rehabilitation for advanced respiratory, cardiac, and neurologic conditions is well evidenced and documented. There's a lot happening in these areas in terms of palliative rehabilitation. So the goal of palliative rehabilitation is to promote independence in self-care activities, improve symptom control, stabilization of functional decline, and provision of emotional support. All this together act to increase independent functionality. This approach is prevention of disuse secondary to disability. So rehabilitation, various methods of rehabilitation. You can see here some of them assisting in their daily living activities, exercising, walking aids. So there are many ways of rehabilitation, and these are few. So different levels at which rehabilitation can be considered. So 3 different levels: level 1, specialist intervention; level 2, team-wide implementation; level 3, overarching values and vision. In level 1, we involve a specialist. It could be an occupational therapist or a physiotherapist who can focus on their respective symptoms. For example, a patient who's bedbound, a physiotherapist can help him from sitting to standing position so that the patient won't be bedbound most of the time. In second stage, where we talk about team-wide implementation, here we, as a team, we primarily focus on patient-centered goal setting. We talk to the patient, identify their priorities, and come up with steps to help them achieve these priorities and goals. For example, giving people an option or a control over the personal care they receive. What are their priorities? What is that they want as first? Supporting them with their activities of daily living. In the third aspect, overarching values and visions, 3 important things to remember when it comes to values of rehabilitation. Empower the patient, keeping in mind the autonomy and dignity. So autonomy, dignity, and empowerment are the 3 important values of rehabilitation which should be respected at every step. Some concepts of palliative rehabilitation. First is preventive rehabilitation. This is an approach to prevent functional deterioration, encouraging the patient to participate in activities of daily living and maintain quality of life. This is otherwise also known as prehabilitation. Second one is restorative rehabilitation. Here we attempt to return the patient to their pre-morbid functional status with little or long-term impairment. Patients here have some functionality remained. And in supportive rehabilitation, we maximize function by increasing self-care ability and mobility in patients with progressive disease. The primary focus here is to maintain self-care and maximize independent functionality. The disease is progressive here, we cannot control that. So the goal here is to maintain their independent functionality by palliative rehabilitation. Interpersonal team involvement. There are various professionals who are involved in providing palliative rehabilitation. Some of them include physical therapist, occupational therapist, speech and language pathologist, nutritionist, psychologist, swallow therapist, nursing, all of them focusing on various aspects of palliative rehabilitation. We'll just discuss about a few responsibilities about each of this therapist. Physical therapist, they manage muscle weakness, deconditioning, help with motor deficits, perform pain interventions like stretching, muscle strengthening exercises, provision of adaptive equipment, education on energy conservation, and therapeutic exercises. They also play an important role in caregiver education on how to use the equipments, how to teach the body mechanics, and fall preventions. Occupational therapists, they help maintain activities of daily living, help with regular work tasks, recreations, use of adaptive equipment to teach the patient how to use the adaptive equipment, and discharge planning. Occupational therapists are very well known to focus on fine motor deficits where we use our hand movements than physical therapists. They also help with the interventions like home assessments, prescription of adaptive equipment, coaching in domestic tasks as to how to perform daily living activities, stress management, and also provide caregiver support. Speech and language pathologists, they address oropharyngeal, laryngeal function and cognitive components in communication, help with feeding and communication by vocal training, visual comprehension, tongue coordination, movements and techniques. They teach these techniques to them, and food management strategies. So various areas where we can see palliative rehabilitation include frailty syndrome, speech and cognitive dysfunction in pediatric palliative care, in advanced heart failure, respiratory illnesses, neurodegenerative conditions. So before we look into each of this, when it comes to a patient, it is important to ask them as to what is important to them and what is that they want as priority. I'm sorry about the clarity of this image, but here in this image, you see so many activities that a patient wants to do. So when a patient comes up to us and says 3 or 4 sentences, it's always important to ask them as to what is bothering them the most. Or if they come up with a couple of wishes or 3 or 4 wishes, ask them what is that they want as first priority. And we can act accordingly, or we can tailor our work according to their needs. So in the first slide, for a patient, it may be important to go out for shopping or go out for a walk with their family members, a holiday, gardening. For someone, it might be important to use restroom all by themselves, a family dinner, visiting friends, gatherings, grandchildren, cycling, story time. So many things that someone wants. But what is the most important thing that they want is something that we should find out. Rehabilitation in patients with frailty syndrome. Frailty syndrome is diagnosed by unintended weight loss, or someone who has unintended weight loss, reduced hand grip strength, slow gait speed, subjective feeling of physical exhaustion, and reduced physical activity levels. All this comprise frailty syndrome. And this is well-recognized syndrome seen in geriatric group of population, and it can lead to a varied number of complications like falls, fractures, screen breakdown, muscle strength, loss of muscle strength, joint stiffness, all impacting quality of life poorly. And if this is recognized in the early stages, this can be reversed with palliative rehabilitation program, where we incorporate tailored exercises, educate them about careful nutritional needs assessments, and support them. This is more important in cancer patients, especially when they're undergoing chemotherapy or radiotherapy, and having complications like nausea and vomiting, which can further worsen the frailty. Physiotherapy programs in some RCT trials have shown to improve fatigue in frailty syndrome patients. Rehabilitation in speech and cognitive dysfunction group of people. This is more commonly seen in stroke and brain injury patients. Palliative rehabilitation help with communication and cognition and assist in optimizing the functioning. For these patients, things like memory books and pharmacological management of agitation and disrupted sleep-wake cycle all together can improve cognitive performance. Training the family and friends and caregivers is also important, as it can create some sense of help to them in their otherwise overwhelming situation. Palliative rehabilitation in pediatrics. Here I'm going to take an example of pediatric hydrocephalus and talk about it. Pediatric hydrocephalus, as such, if there is an excess of pressure building on brain, it can cause damage in due course of time and impair physical and cognitive development of the child. So physical therapist here can help the child reach physical milestones, such as sitting, standing, crawling, and improve child's coordination, balance, and motor skills. These are very important in due course of time because these can help the child, if addressed early, these can help the child function independently in future to some extent. Speech and language pathologists, they primarily focus on developmental delays and communication impairments and assess the child's daily functioning and performance in the school and social interactions. Occupational therapists, they diagnose developmental or physical impairments, help with functions of daily living, fine motor skills, teach fine motor skills, hand-eye coordination movements, reasoning skills, and communication. They also recommend assistive equipment for independence, such as wheelchair or walker, if needed. Clinical social workers, they have a significant role to play here. They usually help the families cope with stress and psychosocial, and also provide psychosocial assessment of the child. They connect families with variety of community resources, such as counseling on how to live with a chronic condition, transportation needs for medical care. They coordinate family dynamics, family care dynamics, like how a child should be taken care on day-to-day basis. Secure sometimes also help secure accommodations while they're being treated at hospital. Next, coming to palliative rehabilitation of advanced cardiac failure or heart failure. Advanced, like we all know, advanced heart failure typically leads to recurrent hospitalizations, especially in the last stages, impacting their physical function. And because of this inactivity, there can be seen some muscle atrophy causing exercise intolerance and deconditioning. And finally, when the skeletal muscles are involved, it can lead to fatigue and dyspnea on exertion. Cardiac rehabilitation is appropriate for patients with class 2 or class 3 heart failure, and there should be a caution about advanced patients with advanced arrhythmias, because these group of patients should not be included into this. Now, there is something called comprehensive cardiac rehabilitation program, where they include various methods of aerobic training, like continuous and interval aerobic training, physical activity counseling, psychosocial support, and risk factor education for weight control and smoking cessation. All together can decrease the symptom burden and help improve their physical function. Multiple studies on exercise demonstrate that it is known to improve exercise tolerance, dyspnea, fatigue, ability to perform activities of daily living, decrease anxiety and depression, and reduce the rates of hospital readmission and cardiac mortality. Palliative rehabilitation in neurodegenerative disorders. First, we'll talk about amyotrophic lateral sclerosis. Like we all know, this is a progressive and degenerative neurologic disease involving both upper motor and lower motor neurons. The upper motor neuron defects include muscle atrophy, axial muscle weakness, respiratory muscle weakness, loss of arm strength, weakness of speech and swallowing. The UMN symptoms include incoordination. These patients are known to have high symptom burden in terms of pain, fatigue, dyspnea, and sialorrhea. And these are the symptoms that we primarily focus in palliative care. These symptoms, along with the symptoms, as the disease progresses, there comes diffuse weakness and wasting, accompanied by dysarthria, dysphagia, and failure of the respiratory muscles, causing respiratory depression. So these patients, if are involved in a multidisciplinary care, can have a good quality of life. At least we cannot stop the progression, but can provide good quality of life. The American European guidelines both strongly emphasize the preference of multidisciplinary team involvement along with palliative rehabilitation for this group of people. These in rehabilitation, palliative rehabilitation interventions primarily focus to prolong and maintain the independence and avoid complications. That cannot stop the disease, but we primarily focus on avoiding complications and maintain independence. Physical therapists may initially start intervening using gait and balance training. So ALS patients are initially started off to be trained in gait and balance by physical therapists. And then as the disease progresses, they may recommend a manual or power wheelchair, how to use it, where all they can use these aids is what physical therapists help them with. When it comes to swallowing and swallowing difficulties, speech and language pathologists may identify compensatory swallowing strategies, help them with behavioral changes, and also the dietary modifications that may increase the safety of swallowing. For dementia, only physiotherapy interventions can improve. Evidence says that physiotherapy interventions can improve quality of life as well as physical skill. When it comes to Parkinson's disease, multidisciplinary rehabilitation, improving sleep quality and physical performance gait and balance can be seen. Evidence also suggests that exercise-dependent plasticity, like physical exercises, can increase their quality of life. This happens through increase in synaptic strength and increase the neurotransmission, thereby improving the plasticity. And also physiotherapy in short term can improve gait, maybe help with gait. Palliative rehabilitation in respiratory illnesses, this is well documented and well evidenced. It combines both the physiological and behavioral tools to improve the lung capacity, especially for breathlessness and deconditioning, and reduce the symptom burden. Commonly used conditions include chronic obstructive pulmonary disease, asthma, interstitial lung disease, bronchiectasis, cystic fibrosis, and lung cancer patients. Here, patients are taught self-management with quality of life and self-efficacy as major goals. Exercise training is important, and that powers the pulmonary rehabilitation and is considered to be the most effective means to minimize dyspnea on exertion. So some guidelines. Pulmonary rehabilitation is known to improve dyspnea, exercise tolerance, reduce anxiety, and also reduce healthcare utilization. The American Thoracic Society defines pulmonary rehabilitation as a multidisciplinary program for patients with chronic respiratory impairment that is individually tailored and designed to optimize physical and social performance with autonomy. There are 4 essential components of this pulmonary rehabilitation program. Number 1, exercise training, which includes strengthening of upper extremity, lower extremity, and upper and lower extremity muscles, and respiratory muscles training. Education, patients are taught about breathing exercises, how to conserve energy, how to simplify work, and end-of-life education. Psychosocial and behavioral intervention, here patients are taught about coping strategies and stress management. And finally, there's something called outcome assessment in the last. Patients with copious and pernicious sputum production, for them, nebulized normal saline and hypertonic saline, along with airway clearance techniques are taught. This may help clear secretions and mucus plugs. Other methods of airway clearance include forced exhalation, postural drainage, positive expiratory pressure, and high-frequency chest wall compressions. All these are done by physiotherapists. Other techniques include strengthening training, inspiratory muscle training, relaxation techniques, breathing regulation skills, and mucus evacuation techniques. All this can reduce the symptom burden to a greater extent. Some interesting data, it is said that pulmonary rehabilitation, mainly breathing retraining and exercises, are known to improve 6-minute walk test, dyspnea, fatigue, emotional function, and the psychological aspects like depression, anxiety, along with exercise tolerance and quality of life at 6 months. So for almost 6 months, these are known to be improved. Caregiver support, this is again an important aspect of palliative rehabilitation. We all know that physical, emotional, and financial costs are most important or most common factors when it comes to caregiver burden, but ongoing sense of responsibility for care and general health risks for caregivers are the significant ones. We usually tend to overlook these things, but ongoing sense of responsibility for care and general health risks are significant. In this situations or in this kind of situations where caregiver burden is significant, short focused inpatient rehabilitation stays and intensive training prior to hospital discharge, teaching them how to take care of the patient at home can markedly improve patient safety and decrease caregiver burden. Training also reduces injury to both patient and caregiver. Effective caregiver training also decreases emotional and psychological stressors. And also, this should also include patient as a part when teaching caregivers, because if patient can take care of himself to a little extent or to some extent, that will definitely reduce the caregiver burden. Important to explain the techniques to patient carefully to maximize their ability on taking care of themselves. Sometimes caregivers and to some extent patients should be trained to instruct other substitute caregivers. Training these substitute caregivers can help with intervals of respite care. Some indications and benefits of palliative rehabilitation. Evidence state that application of palliative rehabilitation is feasible, easy, and provides numerous benefits, both in cancer and non-cancer patients. Some of the benefits include decrease in symptoms, improvements in functions of daily living activities, mobility, mood, fatigue, and lymphedema. There's no separate consensus as to when to refer the patient to palliative rehabilitation, but there are some general considerations. This include frequent falls at home, neurocognitive changes affecting daily life, pain that limits activity and function, interest in pursuing a long-term guided exercise program, caregivers or family members reporting burden, fatigue that limits activity and quality of life, and recent illness exacerbation requiring multiple hospitalizations and a decline in functional status. All these are some considerations where we need to consider palliative rehabilitation, and this can be of a benefit to the patient and caregiver. Some of the challenges for palliative rehabilitation: not much information is available about palliative rehabilitation, and many of these interventions, we are uncertain about many of them. There is limited evidence on efficacy of certain rehabilitative interventions in advanced diseases, so we have to be cautious when using or implementing these interventions. Also, many of these interventions that we use may be inappropriate and or maybe of uncertain benefits. So it is important to have a thorough research or thorough understanding about these interventions before we apply it onto our patients. So again, benefits and burdens of palliative rehabilitation, both on patient and caregivers. Coming to benefits first, for patient, palliative rehabilitation benefits for patients. Patients may be able to set personal short and long-term goals for daily activity. They may be more able to engage in social interactions. They focus on care shifts from wellness and ability rather than illness and disability. So they shift their focus to wellness and ability rather than illness and disability. Benefits for caregivers: there'll be decreased caregiver burden with more time to self-care, and there'll be increased opportunity for non-illness focused interactions with loved ones. Burden for patients: increased pressure to maintain own health and function. So self-burden is what I can say. And increased isolation if the regular contact is with those carrying out caring roles. So if, here, when we introduce physical therapists, occupational therapists, the work is taken by these specialists. So there will be some increased isolation among patients. Burden for caregivers: there's a transfer of decision-making back to the patient and loss of caring identity. The caregiver might feel that they have lost the decision-making capacity for the patient, and fear of raising unrealistic expectations in the patient of their recovery potential. They might feel that these interventions are raising unrealistic expectations in the patient. So when we are planning for palliative rehabilitation, a comprehensive and thorough assessment is important. And this begins with current performance status, previous level of functioning, and the potential for functional improvement in future. These are the three important things that we need to consider before we begin the assessment. Later, we can come up with a personalized plan for palliative rehabilitation, which is patient-centered and based on factors like disease stage, prognostication, symptom burden, comorbidities, cognition, physical and psychological well-being, keeping in mind their expressed goals. Places of care is also, the assessment should also include places of care, whether the patient wants the palliative rehabilitation in the hospital or at home. And this would indirectly determine the intensity of palliative rehabilitation. Like the intensity of palliative rehabilitation might not be the same as it is in hospice when compared to home. And it's also important to have a thorough understanding about support system and financial resources of the patient. Because when the patient is sent back home or discharged, The support, we need to have an idea about the support system to continue the palliative rehabilitation at home. Evidence-based functional assessment tools should be used when preparing a specific protocol, protocol or plan involving an interdisciplinary approach. There are many tools, but evidence-based tools should be used. And then after the therapy is started, it is important to measure or see the difference or perform improvement, or perform to notice various changes in various parameters. That is how we are going to assess whether this is helping the patient or not. And that helps us to proceed further and make future plans. Why is it important to have an early integration? Early integration of personalized palliative rehabilitation can improve the overall quality of life, like we just discussed. Also improves the functional status and help with self-care, including psychosocial, spiritual, and financial well-being of the patient and carer. So moving forward in future, collaboration of governing bodies of both comforting and improved functionality, like palliative and rehabilitation specialists, along with interdisciplinary team, is a proactive approach for holistic and personalized multidimensional care. So these three teams, or maybe I can say comfort, improved functionality with involvement of interdisciplinary team, can provide a holistic and personalized care to patients. Rehabilitation and palliative care, it helps patients gain opportunity, control, independence, resilience, and dignity. Responds quickly to help people to adapt to their illness. It's very difficult for patients and their family members to adapt to the illness in the initial stages. So integrating palliative rehabilitation can help them respond quickly to this and adapt to it. Takes a realistic approach to define goals. We always keep in mind the patient goals, values, and plan rehabilitation accordingly. Is continually evolving, taking its pace from the individual. Can help people prepare for death, yes, and rehabilitation in deteriorating body. These are some evidence-based evidence-based things in palliative rehabilitation. Conclusion, early initiation and integration is important because this can help with life-limiting diseases, helping patient retain individuality with dignity. Personalized palliative rehabilitation is said that it's a tailor-made stitch and it can bring together what the patient envisions themselves by a process of enablement and patient-centered goal setting. Time may be short. It's important. It's important to you. What's important to your patient is important to us. So any symptom or concern impacting on physical, emotional, or social functioning should be considered for palliative care, and any risk of future problems or deconditioning should be considered for rehabilitation. So this group of patients should be referred to palliative rehabilitation involving multidisciplinary teams. So recently, the number of people living with disability and experiencing suffering towards the end of life globally is set to almost double by 2060. This rehabilitation is needed now more than ever. The new WHO policy brief marks an important milestone in integrating palliative rehabilitation into palliative care. Thank you.
Archana. Dr. Gayatri, would you like to say something? Thank you, Archana.
Thank you, Archana. I think when Archana started preparing this topic, when she discussed with me, we all felt it was quite vast and wide applicability and with very blood border margins between medical medicine rehabilitation and palliative care. So it was quite a task to bring some sense and structure to the whole concept. Thank you, Archana, for doing this wonderful work and bringing it all together. So we'll take questions from others. Sharing personal experiences But I must say that it's wide applicability. Like for each symptom and for each disease, we can spend days by itself. And many things like we decided not to bring to normally we in palliative care very commonly we talk about lymphedema, constipation, all like it is wide applicability. So Archana just decided to bring some examples to make sense of what we are discussing today. So yes, we take questions.
Anyone has any question? Students?
Any physiotherapy expert here, occupational therapy expert, or anybody would like to, or anybody for that matter.
Hello, good morning, ma'am. This is Dr. Punita from Coimbatore. I can share my experience I did a small project in palliative rehabilitation while I was at Pallium, India. So I can share my experience. Every patient coming in, they do the FIM score, Functional Independence and Mobility score. Every single patient coming in, especially for stroke or paraplegia or spinal cord trauma. And then they review it every week and they set goals. So goal-based therapy and multidisciplinary thing. And every time the nurse or the physiotherapist will lead that MDT and they discuss how is the goal achieved for the next week. Sometimes it's like just like a respite care. Patients go home, then come back for just caregiver training. The caregiver will be trained by the physiotherapist while at the palliative center. So I observed that it was a nice way of integrating, and the score they were using was some FIM score, and they'll see how it is improved in the next admissions. So that's what I wanted to share with you all. Thank you.
Thank you.
So one thing which I get from your presentation also, which Archana mentioned, is having a proper assessment and making before you make a care plan. So having using some scales, but having some of that core assessment and then involving the multidisciplinary team. Most of the time, even like for me also, this understanding about how the different disciplines can bring in their expertise. We don't have any great knowledge about it, most of us in palliative care, like what an occupational therapist can do or what a speech pathologist can do. So it's very important that we understand and read, have knowledge around that so that we have appropriate referral. But very important team, thank you for sharing, to have multidisciplinary team, and thank you for sharing this experience. Archana, any comment?
No, ma'am. There's one question about.
Yeah. Can you
one
take...
question about, yes, ma'am. There's one question about palliative rehabilitation. Evidence on palliative rehabilitation is only there in head and neck cancers or other cancers? That's the question. So, but what I have found out that the evidence is strong when it comes to head and neck cancers. Maybe the reason behind this is because the issues that they face, especially trismus, cervical dystonias, swallowing, speech and swallowing problems. These are primarily dealt with interdisciplinary teams in palliative rehabilitation, like occupational therapist or speech and swallow specialist, physical therapist with exercises of cervical neck. So maybe in this group of population who are under radiation, who have undergone radiation, the data is significant or strong. That's what I found out.
Maybe some evidence around post-mastectomy and preventing complications, because that is a very traditional way of involving physiotherapists. It's in a very limited way, looking at preventing lymphedema and rehab post-op. Yeah. So Hannah says, are there any ASCO or ESMO recommendation for palliative rehab for any specific cancers? Archana, did you come across any such recommendation?
No. Maybe I'll look into it once again. I'm sorry, but I haven't come across any.
Anyone else knows about it? Maybe it'll be great if you can share.
So Hannah, you can speak if you have read about this. So Hannah.
Hi, good morning, ma'am.
Yes.
Ma'am, actually, they have told like there are multiple recommendations on the head and neck cancer. I was just curious whether any other recommendations on any other cancers.
Okay, so the same question which I think previous
Ma'am, I already asked
name
the
is not
question.
there. Previous iPhone has asked. Yes,
No, ma'am, it was mine only. Like the name
it
was
was your
different.
only. Okay, okay.
Yes, because our population,
So
we
can I? There are so many. Means like although a lot of work has been done in head and neck cancer, because head and neck cancer in post-op or in advanced stage, it is obvious that rehabilitation will work when they especially when they are tracheostomized and when they can't speak, they can't swallow. But definitely patients like phantom limb patients those who cannot walk, those who cannot patient means like when patient is, for example, patient is bedridden or patient is half bedridden, if a rehabilitation person will come and explain that this is the way you can do your day to day activity, it will make a huge difference. And we have seen this, that positive impact which rehabilitation person gives when patient is almost thinking that now I can't do, because we are in a habit of working or our all four limbs day and night and running around here and there. We think that this is the life, but with the limitations of the activity, how a rehabilitation person makes a person active, I think this is what is rehabilitation. So because and it makes a huge difference when rehabilitation person will say, come and say that you can sit down like this, you can walk with this walker, you can walk with this wheelchair. There are so many types of wheelchair in these days. They can go to the washroom, rather than going to the washroom they can use the same wheelchair. So there are so many things which are rehabilitation. And for phantom limb patient, there are so many prostheses available. So these rehabilitation person will come and say, in these days the global disability people are working very hard, that the upper limb amputee and or lower limb amputee, how they can live as near normal as life as possible. So all these advancement the rehabilitation person should know, and rehabilitation person can do very important miracle in patient's life who is thinking almost disappointed and all hopeless. So they can provide hope. And for this, Indian Association of Palliative Care has started a dedicated course for physiotherapies and rehabilitation. This is basically this is led by Dr. Kalpana and Dr. Minakshi, and the physiotherapist which those who are taking part is from AIMS and from Adyar Cancer Institute, and good physiotherapists all over country. So what I suggest that almost 70-80 people are joining. And if you think that you are a physiotherapist, because if you will start thinking that I should have dedicated physiotherapist for my palliative care, you will never get, hardly you will get. So physiotherapists, those who are working in your hospital and coming to help you in your palliative care patients also. So what are the different skills they can learn, what are the extra skills they can learn if they want to take care of palliative care patient? I think this course will give them a very good idea. So um, please ask your rehabilitation and physiotherapist people to join, and it's very very simple online course, and very nominal, absolutely nominal charges for the course. So they should join. And the feedback which we are getting from this course, initially even we were not sure that how it will work. So initially the one or two courses were not that good, but now it is becoming absolutely extraordinary course. And every day they are improving, physiotherapists are improving. So please ask your physiotherapist and rehabilitation people that they should join it. So making a depressed person just thinking on a positive side, this is also rehabilitation. So lot of good things we can do for a person. It's not only just walking around is rehabilitation, but we can contribute in many ways. Thank you very much. So any other Dr. Meenakshi, you want to say something, and Dr. Kalpana, because you are running this course and you are getting the feedback, if you want to add something.
Good morning, ma'am, and good morning, Dr. Gayatri and all the senior faculty. Thank you, Dr. Archana, for your presentation. Like Madam said, we just concluded the fourth IAPC physiotherapy course with over 30 participants. My senior colleague, Dr. Tendril, and Dr. and myself had coordinated this course on behalf of Dr. Sushma Madam and Dr. Kalpana Madam. And we found a very good participation from the physiotherapists all over the country. And the course material also was very well curated. So please encourage your team members to join in when the next course is announced. I have a question actually. I wanted to ask about patients who have tracheostomies. We frequently find that they come with uh, copious secretions. I mean, it is so bothersome because they're all the time trying to cough and clear secretions. And sometimes, we find it is mucoid sputum. Sometimes when the secretions become too much, we start prescribing antibiotics. So I wanted to know whether other seniors and other practitioners can help to tell us, share their experience on how they are managing this, because this is a very frequent, it's very debilitating because the patient really can't go anywhere. All the time they're coughing and this thing is coming out. They have to keep wiping. It's unsightly and it's very disturbing. So any thoughts on this? Thank you.
Gayatri, would you like to say, or anyone? Gayatri?
Yeah, so yeah, this is a very common problem in all of tracheostomy patient. And I would say, like what we have found out is that one of the reasons why they come with this kind of soapy secretion and often it gets infected is because of bad tracheostomy care. They are not taught how to do a tracheostomy. All they're taught about is do suctioning. And what they do is they have this one suction tube and they think tracheostomy care is doing suction. And they keep doing that. The more you stimulate, the more secretion. And more frequently you are putting tubes, the more you're introducing infection. So it becomes a vicious cycle. And when we see them in our palliative care setting, they're like in heightened state of the secretion, infection, that cycle. So when we teach the family about minimizing suction, first initially we have to take out the secretions. After that, minimizing it, that they don't have to do it so frequently, and maintaining that hygiene practice. What we have seen is many patients that have gone home with absolutely no suction requirement. Most of these patients in the home setting, when they go home, they don't use suction at all, because once you get out of that cycle, they calm down, secretion comes down, and the chances of infection also gets down. What really goes down is that these instructions are not given, and they keep poking, and this becomes a vicious cycle. This invariably, this is the sequence which happens.
Any role for nebulized saline, ma'am?
Initially, yes,
saline
when they're in the heightened state, we try to bring down the secretion by infection control, proper culture, because often it is hospital-acquired infection and they're very resistant to most antibiotics. So having a proper culture and then nebulization, calm down the patient and gradually teach the patient and the family about hygienic way of doing suction. Remember how you do it in theaters? We practice such hygiene techniques for suction. Here, nothing of the sort happens. So all they know is to do suction, and it goes on and on. Yeah. Dr. Sai from Puttaparthi. Yes, you have immense experience. Please tell us.
Good morning, ma'am. Thank you so much, Archana ma'am, for the very informative session. So I wanted to ask, like, what is the role of a palliative physician in rehabilitation in a usual palliative setup, and also the team, the nursing role or whatever everyone can have in this rehabilitation, and how practical it is in a usual palliative setup, the rehabilitation is possible, if I can know.
Archana, will you take the question?
So, Dr. Prajwal, like you just said, I would quote the tracheostomy example now. There is a significant role of palliative rehabilitation in our setup, especially dealing with the lung cancers, or especially let's suppose if the patient is a supraglottis cancer and then he underwent tracheostomy, following which he had copious secretions. Now, in this group of patients, like ma'am just explained, tracheostomy care is important. Added to that, in our setup, we also involve our physiotherapist who teaches them exercises where, the simple techniques, just physiotherapy is what we call. And that also aids and helps them a lot with these secretions, along with nebulizations and good nursing care, tracheostomy care. So there is a significant role for group of people, like I just mentioned, interdisciplinary teams, physiotherapists, occupational therapists, all of them together. I think you visited our center where we use all the services and help the patient. So I think, ma'am, do you want to comment on this, like how we use all the group of people to provide
As
complete care?
Pushpa said, we may not have always a full-time physiotherapist in a program. So it's very important all our team members having some basic skills and understanding the need, when to refer, and some basic skills about all these aspects. So all team members should be equally aware. So there was a question about a doctor joining the physiotherapist course. I think we should all have this. We should all do it, and so that we know how to take their help. Yeah. I just want to draw one quick attention to one aspect: advanced disease, like end of life care. I won't say end of life, like advanced disease, especially when the patient is in hospice, and role of physiotherapy. Because often this question is asked when the patient is anyway dying. No, what are you planning to make him walk around? But there they have very special need, which may not be that patient will walk back again, but still there is something we call it as improving mobility, even in the bed. So make him sit up, let him have his food on his own. If can we achieve that at his own pace, leisurely having food, or sit down with the family, simple massage. I've seen many good hospices, they do aromatherapy or massage on the hand, and the touch itself is such a powerful way to make them feel better. Because Archana again and again mentioned about quality of life. So it all means a lot when even end of life care patients are being touched, and family or the caregiver spending time with the patient. All this matters even in end of life. Just taking them out on a wheelchair, making them see sunshine and see the nature. So even in end of life care, there's a significant meaning to rehabilitation and palliative care. So there is some, Suhana has shared something. Suhana, can you tell us? Yes. This is a great one
Level 1 evidence.
Yes, ma'am. One evidence is there. Yes, I was searching the
Dyspnea
literature.
patient.
Yes, ma'am.
And in fact, the dyspnea guideline currently says that the most important intervention in this chronic dyspnea syndrome is rehabilitation. There's breathing, thinking, functioning model. It's no medication. It's all about using fans and then breathing, thinking, functioning. I think all postgraduate students must be so aware of this concept. So it's all about rehab in dyspnea. Even in, I think Dr. Sushma can validate, in chronic low back pain, neck pain.
Yeah. Everywhere there is a great role of dyspnea, great role of rehabilitation. I think there is hardly any role of intervention in such patients. So chronic pain patients, cancer survivors, those who are having pain, I think everywhere there is a huge role of rehabilitation. And what I will advise that everyone should join this course and try to make them means like give them your suggestions to improve it further, because we are ultimately improving with every course, passing course. And maybe we will improve further if a lot of people will join and they will give their suggestions. Because when we come across with a patient who is having a lot of requirement and we are unable to fulfill their requirement, then we come an idea that, oh yes, I should know something more, and this is the way we can improve our courses. So there is no time, 2 more minutes. One permanent tracheostomy patient of CL wish to not live anymore and take his own life. No family except his own unmarried sister. How to take care of such patient to rehabilitate to life? He was very active and taught. I think this is another question, Manish. I don't think that we will be able to take up right now, that if somebody wants to take their life away, how to handle such patients. Quickly, 1 minute, may if you can answer, Gayatri. Otherwise, we will have to stop and we will have to go for work.
So one minute, I would say, when somebody says like that, I will maybe take a step back and find out why he's asking such questions, why he wants to take his life. Often they have some reasons, like not being able to speak, not being able to breathe. So, and once you find out, then intervention accordingly is the most important step towards when the patient asks such questions. Yeah.
Okay, thank you very much, Gayatri and Dr. Gayatri and Archana, for fantastic session. Thank you, Nisha and Archana, again for coordinating everything. Thank you, Dr. Kalpana and Dr. Meenakshi, for having this course for all over country. Fantastic course is going on, and we will keep improving. And based on our today's feedback, also we can add ESMO and other guidelines in the course and our in lecture series, if it is available, the latest one. Thank you, everyone, and we will see you next week before 6:30. Thanks a lot. Have a nice week.